Hi, I'm Jonathan Cheng from UT Southwestern Medical Center in Dallas. These authors have performed a systematic review of 23 papers over a 40-year period ending in 2012. They have selected patients with recurrent or persistent carpal tunnel syndrome in two groups of papers: flap interposition treatment and repeat open decompression. The flap interposition group contained 294 patients with 14 studies and obtained an 86% simple weighted success rate. In the decompression group, the patients had external or internal neurolysis. There were 364 patients with 9 studies and a 75% weighted success rate. There was a statistically significant difference with improved results in the flap group with p-value of 0.001. The odds ratio for success with decompression was 0.50. The incidence of persistent or recurrent disease following carpal tunnel release is approximately 1 to 30% in the literature, with an average at about 5%. The fact that there are numerous options for treatment of these problems indicates that there is no good solution and that many authors are searching for a viable treatment. The use of vascularized tissue is based on an unclear mechanism. It's not clear whether this improves gliding or vascularity, reduces scarring, or provides a physical interposition to the healing transverse carpal ligament following release. Furthermore, the use of non-vascularized nerve wrap, whether they are synthetic or vein-based, further confounds the treatment options. These are different than vascularized tissues, and it is unclear what the benefit is. Studies on carpal tunnel release, whether persistent, recurrent, or primary, suffer from lack of a standardized evaluation. The nerve conduction study is considered a gold standard, but it can be normal in 20 to 30% of symptomatic carpal tunnel patients based on a Mayo study from 1988. It's unclear whether nerve conduction studies improve after release, and therefore they have limited utility for recurrent or persistent disease. Patient self-report measures can be helpful for determining improvement following carpal tunnel release and for diagnosis. The Boston Carpal Tunnel Questionnaire has been developed, and there are others which are also in the development process. Recurrent or persistent carpal tunnel syndrome remains a diagnostic dilemma, with diagnosis primarily based on clinical evaluation. The diagnostician is challenged to determine the difference between nerve injury, incomplete release, and recurrent disease following primary carpal tunnel release. Anatomical localization using the scratch collapse test can be helpful. Timing and symptoms must be considered, including the onset of worsening following release, whether there is new dense numbness or neuropathic pain, and whether there was a substantial interval of improvement following release, subsequently followed by worsening. All studies which were included in this paper were level 4 case series studies. They were selected based on a 4-point scoring system for meta-analysis. It is unclear whether success, as indicated in these papers, is improvement, resolution, and how it was absolutely determined. Most likely, success was not determined on a uniform basis between the papers. I would like to congratulate these authors for evidence-based analysis of the available data. However, there are substantial limitations in the available data, including reporting bias in case reports. For instance, the authors note that they excluded several vein wrap studies which had 100% success based on presumed reporting bias. However, they included 4 studies in the flap group of this paper, which also reported 100% success rate. This accounted for 26 patients. Based on my review of the statistics, this had minimal impact on the flap group overall success rate. The conclusions and the impact of this study are limited in nature, although they are suggestive in support of flap-based revision. The authors correctly and candidly note these limitations. The hand surgery community would benefit from standardized diagnostic and evaluative measures in order to provide further uniformity in the reporting of results following primary and secondary carpal tunnel release. Important follow-up work to this paper includes a direct trial to compare flap-based versus direct carpal tunnel release for recurrent or persistent disease. This would be a difficult trial requiring a specialized practice with a large amount of secondary surgery or multi-institutional organization in order to report sufficient numbers for statistical analysis. Such a trial could be envisioned to have a randomized prospective design, which would require large numbers of patients, but would be very helpful for practitioners performing carpal tunnel release. It is still unclear how to diagnose recurrent versus persistent disease, and treatments may theoretically be different for recurrent and persistent disease due to anatomical localization. Also, those performing this prospective study would need to determine what kind of flap to use with consideration of the morbidity and the difficulty of flap performance. The hypothenar fat flap is a very common currently used flap for this purpose and may be the most appropriate choice. Thank you.